Welcome to This Explainer. Okay, today we are tackling something that literally touches every single one of us in a very real, very personal way. We're talking about healthcare costs. It's a shared pain point we all feel, right? Whether you're opening a medical bill you totally weren't expecting, or just looking at the premiums deducted from your paycheck every month. But today, we get to explore this issue through a completely different lens. We're looking at a fascinating structural analysis paper that really challenges and reframes how we think about the American medical industrial complex. We're going to unpack its findings step by step, and trust me, it is an eye-opener.
So the researchers kick things off with a massive paradox. It's the core question that drives their entire critique. Why does the United States spend double on healthcare compared to its global peers, but actually experience shorter lifespans? To really understand the paper's findings here, we kind of have to let go of the idea that our system is simply broken or inefficient and just look at the actual data.
To really wrap our heads around this, let's look at the sheer scale of the numbers. According to the 2024 data analyzed in the paper, the U.S. spends a whopping 18% of its entire gross domestic product on healthcare. That is a staggering nearly $15,000 per person every single year. To put that into perspective, comparable high-income nations spend around 11% of their GDP. We are spending almost double, yet we are the only industrialized nation failing to guarantee universal coverage for our citizens. And a really key point the paper makes here is that this 18% is money that is already leaving the economy. That sets up a crucial realization about how we view taxes a little later on.
All right, Section 1, the trillion-dollar diagnosis.
Okay, let's dive into this. The researchers make a pretty bold claim here. They argue our system isn't actually broken at all. Actually, scratch that. It's functioning exactly as it was designed to. But that design is meant to extract wealth, not necessarily optimize our public health. The first major vector for this is what the paper calls a private administrative tax. Notice this crazy 2-to-1 ratio from the data. In 2023, hospital administrative expenditures reached $687 billion. Direct patient care, just $346 billion. The researchers point out that our incredibly fragmented system, where every single provider has to negotiate and bill thousands of different insurance plans, all with unique rules, creates this massive, hidden structural bloat.
To bring those macro numbers down to a micro, relatable level, the paper highlights this incredible statistic. Get this. It costs an American primary care physician an average of $20.49 just to submit a single bill to an insurance company. When you multiply that across an entire year, it translates to nearly $100,000 per physician entirely wasted on billing and insurance-related overhead. No way, right? But that's the reality.
Moving right along to Section 2, the hidden administrative tax.
So, if the system is designed to extract funds rather than reinvest them into actual clinical care, where exactly are these massive administrative costs ending up? Well, the paper meticulously tracks this flow of capital. The data reveals how these administrative costs translate directly into record-breaking corporate profits. In 2024, the 7 largest publicly traded health insurers took in $71.3 billion in combined profits. The CEOs of these companies took home over $146 million in compensation. And look at the gross margins. Medicare Advantage plans yielded an incredible $1,655 in gross margin per enrollee. The paper essentially characterizes this as an extractive monopoly funneling working-class wealth right to financial elites.
Which brings us to Section 3, deconstructing the tax myth.
Now, whenever a transition to universal healthcare is brought up, there is a very natural, entirely understandable reaction: the fear of massive tax hikes. Nobody wants to see their taxes skyrocket, but the researchers argue we are already paying a massive hidden tax. Now, what's really interesting about this slide is how it breaks down your current household healthcare liability. You have your employee premium, which is what's deducted from your paycheck. You have your deductible and your out-of-pocket copays. But crucially, you also have the employer portion, what your employer pays. Standard economic modeling shows this employer portion isn't just a nice gift, it's money that would otherwise go directly to you as taxable cash wages. So you are currently paying a massive regressive tax on your labor.
The paper then models out a single-payer transition. And look at what happens. That whole previous equation, the premiums, deductibles, copays, it basically drops to absolute zero. In its place is a progressive public tax. By replacing all those fragmented premiums and copays with a streamlined public system, total healthcare costs actually go down for the vast majority of families. Because public tax financing is progressive and completely eliminates all that administrative bloat we talked about earlier, the paper calculates that the absolute reduction in private costs far exceeds any marginal tax increase.
And on a national level, the savings are just immense. I honestly found this part incredibly surprising.
According to updated 2025 modeling cited in the paper, transitioning to a universal single-payer system wouldn't bankrupt the economy. It would actually yield a net savings of $579 billion annually. And that's even while expanding comprehensive coverage to all uninsured Americans. Let's move to Section 4 and see how this builds. The medical price illusion. So, to maintain those sky-high profits we discussed earlier, hospitals use this highly guarded database called a chargemaster to set arbitrary prices that literally have no connection to the actual cost of delivering care. You can see the reality of this markup right here through comparative data. Take a standard broken arm requiring surgical fixation. In the US, the final bill for an uninsured or out-of-network patient can reach nearly $98,000, with extreme markups on things like anesthesia and basic orthopedic screws. In stark contrast, under the UK's National Health Service, this identical emergency procedure costs the resident $0 out of pocket. Or let's consider something as fundamental as having a baby. A standard delivery in the US averages $30,000 without insurance, and even fully insured Americans frequently pay over $3,000 out of their own pockets. Compare that to residents in peer nations like Germany, the UK, Australia, and Canada, where the actual out-of-pocket cost for bringing a child into the world is, again, $0. The pharmaceutical sector operates under a very similar extractive structure, heavily protected by patents. The data here is incredibly eye-opening. A standard unit of insulin costs roughly $98 in the US, compared to an $8 average in peer nations. A 2-pack of life-saving EpiPens, that can cost upwards of $700 in America, while costing a tiny fraction of that globally. The paper points out that these aren't really free market prices, they're monopoly prices.
Now for Section 5, the wait time deception. Now, a very rational concern we hear all the time about universal care is massive wait times. We're often told that our market-based system, for all its flaws, at least ensures rapid access to doctors. The researchers challenge this by showing us the current reality in the U.S. The U.S. already has significant and growing wait times. By 2025, the average wait for a new patient appointment across major specialties hit 31 days. For an OB/GYN, it's almost 42 days. In major geographic hubs like Boston, the average wait time across specialties is an astonishing 67 days. Oh, and if you are on Medicaid, almost half of these offices won't even accept your insurance in the first place.
And it gets deeper. The paper details how insurers actively manufacture wait times through a process called prior authorization. Basically, physicians must ask the insurance company for permission before providing standard care. The average practice does this 39 times a week. That wastes 13 hours of labor. This isn't just annoying paperwork, it's a structural barrier to care. More alarmingly, 26% of surveyed physicians reported that these administrative delays led directly to a serious adverse event for their patients, including things like hospitalization or permanent impairment. So the researchers make this really profound point. The US doesn't actually avoid rationing care. We just ration it by price. In 2025, 36% of US adults postponed or skipped needed medical care purely because of the cost. Millions of Americans are forced into painful financial trade-offs just to stay healthy, borrowing money, skipping meals, or cutting back on utilities.
So the crucial point is, where do we go from here? Section 6, a synthesized universal solution. Before getting to the fix, the paper looks at the human cost of this structural design. The physiological outcomes demonstrate that despite spending the absolute most globally, the US gets a terrible return on investment. US life expectancy is roughly 79 years. That lags behind peers like Spain, Japan, and Switzerland by 5 full years. Even more tragic is our rate of avoidable mortality. These are deaths that could have been prevented with timely care. The US rate is nearly double that of countries like Germany or France. We are basically paying more to die younger.
The proposed solution here, a transition to a single-payer system, isn't presented as some wild, untested ideology. The paper actually suggests a really pragmatic synthesis of models that already work globally. They suggest taking the administrative simplicity of the UK's tax-funded NHS to completely eliminate billing waste, and combining that with models used in Germany and Japan. For example, Germany utilizes non-profit sickness funds, which are essentially heavily regulated insurers that are legally not allowed to extract profit from basic care. And Japan relies on strict all-payer rate setting. All that means is every hospital and insurer must legally agree to one standard, mandated price list for procedures. That immediately ends the arbitrary markup game we saw earlier.
So if you take all this together, what the paper ultimately concludes is that by removing these financialized middlemen and treating healthcare as a true public utility, we can achieve two huge things simultaneously. First, we reclaim massive amounts of wealth for the working class by eliminating that private administrative tax. And second, we finally optimize clinical outcomes, aligning American health with the standards of the rest of the developed world.
I want to leave you with a really provocative question straight from the core of the researcher's analysis. Is a healthcare system designed for corporate profit truly capable of optimizing public health? The data we've explored today suggests a pretty structural answer. It invites us all to rethink not just how we pay for care, but what the fundamental purpose of our healthcare system should actually be in the first place. Thanks so much for joining me on this explainer, and keep learning.